Hi, my name is Josh Beckman. I'm a member of the board of VIVA Physicians, and we have all been having lots of conversations about the recent landmark trial, Voyager. As a result, we thought maybe by bringing together a multidisciplinary group and having a conversation together and with you, we could better understand the data as it's come out. On the call today will be Peter Schneider, a vascular surgeon from UCSF, John Laird, an interventional cardiology from Adventist St. Helena Hospital, Saher Sabri, an interventional radiologist from MedStar Washington Hospital Center, Marc Bonaca, a vascular medicine practitioner from the University of Colorado, and our special guest, the PI of the Voyager trial, and myself, Josh Beckman, a vascular medicine person from Vanderbilt. With that, I'm going to throw this over to Marc Bonaca so that he can go through some of the salient results of the recent Voyager trial. Marc?
Thank you, Josh. So Voyager PAD was designed to be a pragmatic trial and answer a very specific question. In patients with lower extremity peripheral artery disease with symptoms, either claudication or critical limb ischemia, on top of best possible available care, meaning aspirin, statin, clopidogrel if you wanted to use it, with the addition of rivaroxaban versus placebo, reduce major adverse events of the heart, brain, and leg. And those efficacy endpoints are listed here. And then what's the safety of such a strategy in a pretty vulnerable population undergoing revascularization? So here's the design schema here, and I think you've all seen it, but it was felt to be a pragmatic trial, no enrichment for cardiovascular risk or limb risk, just an all-comers population needing lower extremity revascularization. The primary results were presented at the American College of Cardiology, and I'm showing you here. It was a positive trial. Curves separate early and continue to separate over time. It was positive at 6 months with the number needed to treat of 65. And even at 3 years, then we have a 2.6% absolute risk reduction and a number needed to treat of 39. So early benefit, continued benefit over time, and number needed to treat even at 6 months that is reasonable and quite favorable at 3 years. In terms of the components of the primary endpoint, they're listed here. Of note, you'll look on the red, acute limb ischemia was the most frequent adverse outcome in patients who were randomized to placebo, 7.74%. So big risk there, and we can talk a little bit about what that means, but that's what you see in this population, much more common than ischemic stroke or myocardial infarction. And overall, there was consistency amongst those components with the exception of CV death, where we didn't see a benefit. There were a series of secondary outcomes are listed here in the order of hierarchical testing. So as you move from left to right, all those green boxes were significantly reduced. I'll point out two. The second group of bars here, this is the need for an unplanned index limb revascularization for ischemia. So you do your intervention, and the patient needs to come back with an ischemic problem in that limb for an unplanned revasc. There's a 2.5% absolute risk reduction. And the fourth set of bars is essentially the primary composite endpoint with all-cause mortality. So this is essentially event-free survival. And this was significantly reduced with an absolute risk reduction of 2.6%. We did not see a difference in all-cause mortality. So, I talked about the pragmatic nature. That meant that a lot of folks could come into the trial. This is the efficacy subgroups, it's just some key subgroups. And you can see a few things here. First of all, there's consistency in the elderly. That's a vulnerable population. You can see the same benefit there. You can see the same benefit in those that did or did not have coronary disease, but probably most important for this conversation, in the patients who had critical limb ischemia, the risk is really high, have the same benefit there, and the same benefit whether patients underwent surgical or endovascular revascularization. Like all antithrombotics, there's a price to pay. These are the safety outcomes. In the far left, the principal safety outcome of TIMI major bleeding. The rates were higher with rivaroxaban, an absolute risk increase of 0.8%, or about 0.25% per year. You can see all the different bleeding measurements here. No irreversible harm events like ICH or fatal. And ISTH major, more sensitive bleeding outcome was also increased around 0.5% per year. Same hazard ratios, TIMI major bleeding. One thing that wasn't shown at the ACC, but I think important for the folks treating this population, were procedural bleeds. So on the left, for the index revascularization, how many times did someone have to go back for management of bleeding related to therapy? And you can see here that was balanced between arms. There was no significant difference. So this was giving the drug a median 5 days after the intervention, some group earlier, of course. And then on the right, any intervention during follow-up. The patient comes back 6 months later, needs another revasc. What was the rate of bleeding associated with that procedure? And you can see they were balanced as on the slide. So to summarize it all, and we'll get into some discussion, if you follow this strategy in 10,000 patients for 1 year, in all comers, this isn't a subgroup, this is the risk benefit. It's about a 6-fold benefit to risk ratio with 181 events prevented for 29 bleeds caused, but no increase in intracranial hemorrhage or fatal bleeding. And sometimes you want to get a sense of what the timing is, and this is a net benefit slide. Red is bleeding, blue are those efficacy outcomes prevented. And you can see even by 90 days, you have a significant benefit relative to the risk. You have a net benefit by 90 days, and that benefit just grows over time. The bleeders bleed early, and there's a fairly stable rate, but no increase over time. Now, the key subgroup of clopidogrel has been discussed, and I'll just show 2 slides on this. Here on the left side, patients who were given background clopidogrel; on the right, patients that weren't. What you'll see is that overall there was no effect modification. But if you take a close look at these KM curves, at a median of 30 days, where most patients stopped clopidogrel, you can see an inflection point for bleeding on the left. So there's clearly more bleeding if you were getting triple therapy with clopidogrel. And after you stop clopidogrel, you can see that the curves are roughly parallel. And the net increase with RIVA in that group is 0.2% after clopidogrel was stopped. If you don't give any clopidogrel on the right, there's less bleeding, but the net is 0.3%. So RIVA does the same in either group, but triple therapy for the period you're on it is associated with more bleeding. Now, this is ISTH major, which is sort of moderate bleeding, not severe outcomes, but still there are impacts. And I think this is a key observation here. If you're going to use clopidogrel, what duration? Well, for those that used a longer duration on the left, there was a bigger bleeding excess. There was a 2.1% excess at 6 months. Shorter duration, less than 30 days, less than or equal to 30 days, a third of that rate, 0.7% with rivaroxaban. So I'm just going to end on this slide so we can have some discussion. When we talk about the clopidogrel, it's kind of confusing of what the comparison is here. And I think the take home from that on the left and then on the right is whether or not you use clopidogrel, the benefit of rivaroxaban is the same. You can see in these green boxes, there's an absolute risk reduction of around 2.5%. Whether or not you use clopidogrel, so a number needed to treat of 50 or less. And the bleeding is very similar, an absolute increase of about 0.5 to 1%. So the risk benefit is positive in both and quite favorable. And then we can talk a little bit more about how that might impact strategies. So let me pause there and turn it back to you, Josh.
That sounds great, Mark. One quick question to start off this conversation. I've had conversations with folks who've looked at the slide that you just presented, and they were interested to understand why it looked like there was a higher event rate in the group without clopidogrel than the group with, and they wanted to know if it's the clopidogrel that's making a difference, or maybe is there something about the groups themselves that could give you different numbers?
Yeah, so that's a great question, and maybe I'll just bring that slide up for a moment so that I can point out to what you're talking about. So if you look at the red lines at the top, 18.3% with clopidogrel, 21.5% without. And so you might be tempted to say, well, geez, looks like clopidogrel works. The truth is that these are non-informative comparisons. These groups are totally different populations. Group on the right, primarily treated with surgery, higher risk population, and the event rates there reflect the risk of the population and don't represent any benefit of clopidogrel. So we have to be careful not to compare left to right, but really within each panel look down. Does that make sense?
Yeah, I think so. Sahar, what you and I were talking about clopidogrel a little bit earlier this week. What are your thoughts?
So, I mean, looking at clopidogrel and looking at the patients who receive clopidogrel, and I noticed that in the 91% of the patients who received clopidogrel were in the endovascular arm rather than the surgical arm. So now when we talk about, that group, it's not homogeneous. It's not just clopidogrel. There's another factor, which is the endovascular versus surgical route. And so that is something that we just need to keep in mind. As an interventionalist, when I look at this, the main question is, what medicine do I put my patient on after revascularization? This is what this whole study is all about. And it is, are we trying to generalize an overall outcome that is included surgical and endovascular patients when it comes to clopidogrel, when we know that most of the vascular patients, that the surgical patient did not actually receive clopidogrel. So how do you try to figure that out? And is there a way to look into the data further and separate the endovascular from the open surgical cohorts?
Yeah, I'll just address that for a second. I think that's a great question. I mean, again, as a pragmatic trial, you have surgical, you have endo, you have clopi, no clopi. And so this, the goal then is really to provide data to answer those questions. I think one sort of sneak peek at that, and I'll just share this, is this forest plot where we look at the subgroups. And, what you see here is that you're absolutely right. Those with surgery largely did not receive clopidogrel. Those with endo largely did. What you can see is the benefit is essentially the same for both groups. Now, when we present these separate subgroups, we'll also look at with and without clopidogrel. So we have data coming out from just the endovascular group. And as you'd imagine, you can see that there are different drug-coated products, atherectomy, different levels of disease. And so we'll be slicing and dicing it multiple ways. All of it so far appears very consistent in terms of the benefit of rivaroxaban. And I'll tell you, even within the endo group, there are some that didn't get clopidogrel, and the benefit of rivaroxaban looks the same. But those data will be coming out.
So I think, would it be safe to say that you included patients who needed both surgical and endovascular revascularization, because that sort of makes up all the PAD patients who are coming through and getting revascularization?
Yes, it was an all-comer strategy, regardless of how you're doing it. And, recognizing practice patterns depend a bit on geography and where you are. And so it was really about the patients and the disease state and the setting.
All right, John Laird, I think, has a comment.
Yeah, I think, Josh, for the endovascular specialist, there's still going to be a fair amount of uncertainty even after this very well done trial. Because primarily the de facto standard of care for us has been aspirin and clopidogrel. The duration of that therapy is really not clear, but now with drug-eluting stents in the periphery, we've tended to use dual antiplatelet therapy for a longer period of time. And at the end of the day, what we don't know from this trial is, would it be better to go with long-term dual antiplatelet therapy versus this strategy of long-term aspirin plus rivaroxaban? And, there's going to be some heterogeneous treatment strategies here with patients, whether we're using atherectomy or whether we're using just balloon angioplasty or whether we're using drug-coated balloons or drug-eluting stents, where we would normally tend to use Plavix for longer. So, Mark, I'd be interested in your thoughts on that.
Well, I think it's a great comment. I mean, the standard of care has been in endo to largely use DAPT, and the durations are highly variable depending on practice pattern. We saw it in the trial. We allowed up to 6 months, and some people said that's not long enough. But actually, when you take a look at what people did, it was about 30 days on median. By 90 days, everyone was off. And, I think there are a couple data points. One, Atlas 2, although a coronary population, a lot of stented patients, there was a reduction in stent thrombosis with rivaroxaban versus placebo on top of DAPT. So I think, if the question is stent protection, Riva, there's actually reasonable data from this and from Atlas 2 that this is efficacious. And then on the flip side, it's worth examining the benefit of clopi in this population. I mean, there aren't a lot of data to show that it provides a lot of benefit in the limb or systemic benefit. And so I think got to weigh those two things. But I think the community is going to grapple with that question for a while.
I think one of the benefits of this trial is that with 6,500 people in this trial, we're going to be able to know the answer to some of those questions. Like, I'm sure that when Will Hyatt sends in the clopidogrel paper that was based on his presentation at ACC, we're going to have some efficacy understanding of the use of clopidogrel in shorter and longer durations. The other thing I would suggest, and I think this is really tantalizing, is that there were a lot of people who had drug-coated and drug-eluting technologies. I don't remember the exact number, but I know that it's more than 1,000. And so there will be a lot of folks for us to take a look at to see and find the answer to John's question exactly. I don't think we're not going to have prospective trials on clopidogrel use ever, but I think we're going to get a good sense from this data, which is the largest PAD interventional study ever done. Kudos should be applied. And to get a sense for what you just said, is there a benefit to longer versus shorter? Is there a benefit to longer versus shorter with drug-coated or drug-eluting technologies or not? And for me, I think one of the early take-homes is that the reduction in vascular events is something that should be really exciting to everybody who does interventional procedures, because this really has the ability to make your outcomes better, independent of the DAP conversation. But one of the groups I'm really interested to hear about would be the surgeons, and how surgeons would think about this in terms of surgical therapies, because a lot of everybody on this call either does or refers for endo, but there's really just one of us who will take a scalpel and make a difference. So Peter, what do you think?
Yeah, thanks, Josh. As Mark said, this is a pragmatic trial, so about 1/3 of the patients in each group had open surgery. So in that setting, I mean, I think there are a couple things that stand out to me. One is that I think over the years, we've given a little bit of short shrift to the endpoint of acute limb ischemia on a return patient. I think we've underestimated how bad it is and how frequently it happens. And that just turns out to be the thing that seems to be most benefited or most prevented, let's say, from using this protocol. So that was, I think, of high interest. And I think it will be of high interest to surgeons. The challenge for us that do open surgery is that we take peri-procedural bleeding, really any kind of bleeding, since we're the bleeding experts for the entire hospital. We take it, very personally, and we're always looking for a way to minimize it. And so the fact that there was more major bleeding in the rivaroxaban group, that's concerning. At the same time, the things we worry about most, which is fatal bleeding and intracranial hemorrhage, they weren't more in the rivaroxaban group. So that just sort of provides grist for the mill to say that we strongly consider how to use this, as you said, to get better outcomes. We could be doing the exact same procedures and getting better outcomes. That's extremely attractive. And then lastly, I would just say this issue of the timing and what to do with the clopidogrel. Well, you all know from working with your surgeons in your hospitals that we're all very individualistic about our willingness to do open surgery on patients with dual antiplatelet agents. For us, this was a culture change. Well, now it's going to be an additional culture change to consider, the rivaroxaban versus triple therapy, including dual antiplatelet, et cetera. So I think it takes time. It's going to take time for culture change within an institution. And maybe there will be some subgroup analysis or further studies that help us understand the timing better of the cessation of one therapy and the initiation of another.
So Mark, I'm going to ask you 3 questions based on what Peter said. One, can you tell us when the rivaroxaban was usually added in the study? 2, I know you have a very good slide that compares ALI and STEMI, so people can get a sense of how bad each of them are. So maybe you could put that up for our audience. And then 3, John Laird had a question about whether or not you have data on prosthetic bypasses as well. So maybe those 3 quick informative things.
Yeah, so thank you. In terms of the timing, the median was 5 days after the intervention. And what was pragmatic about this trial is we said, you're good clinicians, start the drug when you have hemostasis. Okay, so for every patient, that's different depending on what you did. And we had patients starting as early as a day or 2, after the intervention. Some patients were 7 or 8 days after. And so I think, the low bleeding rate, the procedural bleeding rate, says the clinicians in this trial were really good at knowing when it was time to start an antithrombotic. And of course, that's what people decide every day. So I think it is very practical in that sense. Anywhere from 1 to 10 days, you can start it when you think you have hemostasis and the bleeding risk is acceptable. And that's what was done in the study. And we can present all those data, but the median was 5 days. In terms of ALI, I'll share this slide. I learned about acute limb ischemia from Josh when I trained with him at the Brigham, and from a paper from Mark Krieger and Mike Conti in the New England Journal of Medicine. And then I started to see it, and it's quite frightening when a patient comes in with it, cold dead leg. I think a lot of cardiologists don't recognize this because they don't see it in practice. But acute limb ischemia is exactly like a STEMI or ST elevation MI. It's complete occlusion of a conduit artery to a large area of the body, to a large area of muscle, and time is muscle. How fast you get reperfused determines the outcome. And obviously, if you wait too long, you have irreversible harm or loss of tissue. We measure troponin in MI. We see CKs and potassium go up in ALI. Reperfusion injury is common in both. And you can see from the slides there on the left, the zone of necrosis, and depending on how much LV dysfunction you get, just depends on how early you reperfuse. On the right, it's the same, depending on how fast, where the level of occlusion is and how fast you reperfuse, it determines the amount of tissue loss. But I think what's really striking is at the bottom, outcomes after ALI are worse in many ways than STEMI. Mortality is higher, 12% at a year. Recurrent MACE events are higher. Recurrent acute limb ischemia happens to 1 in 4, and about a quarter lose a limb at 1 year versus, the irreversible harm leading to heart failure, about 7%. So I'm not trying to say STEMI is good, but ALI is a really bad event. And the data I'm showing on this slide are a bit optimistic because they're from a trial, not from real world data. It looks much worse in real world data.
I'm sure that there must be some folks who have prosthetic bypasses, and that data will come out later.
Yes.
Let me ask the next question. So there wasn't much of a difference in mortality between the two groups, with or without rivaroxaban. Does that tell us about the medicine, or does that tell us about the population?
Yeah, I think this is one of the most interesting parts of the trial. We've all been trained to understand that patients with PAD have coronary disease and die of cardiovascular causes. And that's based on observational data where you don't know a lot about the specifics of what they died from. Euclid and Voyager are telling a very different story. Only a third of these patients had known coronary disease. Less than 10%, around 10%, had plaque rupture or MI in the past. When you look at the causes of death, overwhelmingly in this population, it's cancer and infections, non-cardiovascular causes. And even when you look at the cardiovascular causes, recognize that we included unknown death in CV death to be conservative here in case there was a bleeding issue, which there clearly isn't. The unknown deaths, when you look at those patients, are patients with metastatic cancer, with infections, and so on. So the reality is this is a really, really sick population. The mortality rate exceeds that of MI populations of the same duration for MI, stroke, and all the composites. And they're just really sick. This is what happens to them. And they're not dying of MIs. They're dying of things that unfortunately antithrombotics don't modify.
Sahar has a comment.
Yeah, I'm just going to go back to the ALI part. And I think it's really impressive for the study to show this absolute reduction in ALI. And I think it's really meaningful for us to have, the same procedure and have different outcomes if we add a drug in relation to ALI. I go back to the endovascular and the surgical part, the hazard ratio was 0.9 for the endovascular part, and that's a composite, outcome of all-cause mortality and including the cardiovascular and vascular events. What we really interested in, and will, sell me on this, is if there's a reduction in ALI in the endovascular population. I think this will be a game changer because, having an ALI in an endovascular patient is really difficult to treat and is a big game changer. So if we manage to prove that adding rivaroxaban to whatever regimen we're taking will decrease ALI in endovascular population, that'll be huge. And hopefully the further analysis of the data will show that, disputed or not.
What do you guys think is the necessary information or data to come out from the trial to help understand how to incorporate these findings into your practice? Let's start off with John Laird.
Well, I think, again, from the endovascular standpoint, the Plavix clopidogrel issue is a key one. Get a sense for when we can safely stop the clopidogrel, how well this regimen works in our stented patients, particularly those that receive drug-eluting stents. Because if we get some comfort level with the good outcomes and lack of stent thrombosis in that patient population, this will really be a game changer, I think, for us.
How about you, Sahir?
Yeah, I think for us, the timing is important. I mean, right now, looking at the study, without looking at it in a lot of details, it looks like I'm going to use triple therapy for a month and then do Rivaroxaban and aspirin afterwards, right? I mean, that's the assumption. If we can, looking at this algorithm and see if it worked for endovascular, I think that'll be great. So the timing of when to stop clopidogrel, especially for drug-eluting, because most of the drug-eluting, all the drug-eluting, trials included, clopidogrel for 1 to 3 months. So not giving any of that is going to be problematic for most of us. And I think that trial will show that almost all of these patients did receive it. So now the question is, how long did you receive it before you saw a bleeding outcome, which seems to be 30 days, but it's good to look at that subgroup and confirm that that's the case.
How about you, Peter Schneider?
Yeah, so I agree with what John and Sahir said about the endovascular patients. And you worry about stent protection, et cetera, and periprocedural dual antiplatelets. But let me just comment on the surgery patients. I think the trial organizers did a smart thing, and that is let the doctors figure out, when to start the medication. Nevertheless, there's probably a wide range of opinions about that. And it'd be great to again, incorporating it into the practice means that you have an algorithm, you have a flow, a patient flow. And so just defining that a little better would be extremely helpful. What's the safest and most efficacious way to make that transition?
All right. And with that, I'm going to say thanks, everybody, for participating. I think it's really great for us and really lucky for us to have the PI of this trial give us his insights. And I think it's really helpful to begin to discuss results of landmark trials so we can begin to understand their impact on our practice and our patients' outcomes. With that, I'll say thanks very much for tuning in, and hopefully we'll see you at the meeting. Be good and be safe.